Hey guys, and welcome back to my channel. My name's Kris. I am a newly fellowed GP here in Australia, and today I'm going to be talking to you about discharge summaries. So the month of January brings a lot with it. A new year, basically the middle of summer where I am, and it also brings a lot of new graduates into the health system here in Australia. Congratulations to the interns of 2021 on starting their journey. Now, I was an intern in 2017 and not much has changed, but it also feels like everything has changed since then. So if I say something that is slightly outdated or you disagree with, that's fine. This is just kind of a reflection on my experiences, but the topic of today is discharge summaries. So I had a little personal record in the hospital system, and in one night shift I did over 100 discharge summaries. And that may sound incredible, but now I'm cringing because they were probably crap. So when I went to university, we were taught how to do discharge summaries as a medical student. We had a couple of assignments on it, and when we did placements in different hospital systems, we also began to do them, basically like unpaid interns. The problem is, however, I now see discharge summaries so differently because I'm on the receiving end of it. So what I want to do today is just give you kind of a newly fellow GP's perspective on what a good discharge summary does and doesn't have. So if you're interested, of course, keep watching. Now, I will just note that I have my phone here because I'm looking at a patient's discharge summary, so that's 6 times fast, discharge summary as I go along, so I can tell you exactly what the layout is here in Queensland. Mind you, every state and the public versus private system will vary. So this is the public system in Queensland, but basically a discharge summary should have all of the things I'm going to mention. So I will do my very best to take a screenshot of this and line out all of her actual information so you can just see the format, and we'll put that in editing. Good luck editing, Kris. But let's have a look here. So basically, starting with it, you can see a lot of information about the patient, episode details, so who the patient was admitted under, on what date, at what time, and when they were discharged, and was it discharged to home, another facility, etc. The first most important thing, and when you're putting in a discharge summary, the enterprise discharge summary, I think it's just called enterprise discharge summaries. Anyway, the program when you're writing it is the presenting complaint or reason for admission. Here, one of the errors I see is a lot of people copy and paste the emergency department notes. Well, this can be very, very good. It's also filled with a lot of unnecessary information. I want to know why they presented, how they presented, and what made them admitted. So for example, if someone presents with abdominal pain that led to appendicitis, well, that they found out was appendicitis and led to surgery, that's the kind of stuff I want to know. Did they present with vomiting? Was it diarrhea? Was it abdominal pain? Was it vague fever, etc.? So basically, short and sweet is good. More details if pertinent is obviously warranted, but put in there age, gender, what symptoms they presented with, and what they ended up having. So using another example, a 27-year-old female presented to the emergency department with fever and later diagnosed with pneumonia. This was on a background of smoking or not smoking, having asthma, not having asthma, that sort of thing. Yes, you may be thinking to yourself, your GP or the GP of the patient should know all of the past medical history and what's pertinent and not, but sometimes patients don't go and see the same GP. So just put in all the interesting stuff, the stuff that really makes a difference to that patient's care. This discharge summary also has a lot of information about their past medical history, which can be useful, but there is actually a section for that. So going down, there's the principal diagnosis. So a lower respiratory infection or appendicitis or whatnot. So kind of copied over, but it's still important, mostly for coding. So a side tangent very quickly, this is how hospitals make money, and also for their stats. So making sure that you put in the right diagnoses, even if it's just a principal one, it isn't actually what they ended up having. There's also secondary diagnoses. So I may have come into hospital with pneumonia, but then I may have had a fall and fractured my hip. Or it may be that I ended up having some blood issues or whatnot. So secondary stuff that happened. Then there's the previous medical history. So this is the past medical history. Keeping this up to date is super important, especially for those who come to the hospital a lot. So the inpatient clinical management comes next. And this is the part where I got it so wrong as an intern. And I'm so sorry to any fellows who got my discharge summaries. Basically, it's the important stuff. So they were admitted on day 1, on day 2 they developed a fever, day 3, blah, 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 blah. It's not actually relevant to GPs. We do care, but we're usually reading these when the patient's in the room, they say, I was admitted to hospital, and you're like, were you? Let me have a look. Oh, there's your discharge summary. So this one's actually really, really good. So they said, commenced on IV antibiotics, changed to oral antibiotics, started this one, investigated, found X, Y, Z, discharged on day 6. Perfect. I don't actually care too much about how many litres of saline, or they went through 4 different antibiotics before they found the right one, that sort of thing. I want to know what actually happened and what will change the community management of this patient. So this one, discharged on orals, I need to know that. What antibiotics they did have, I need to know that. Did they change any regulars? I need to know that. So, you know, really, really good here. Then there's complications. So did anything happen in hospital that complicated things? So falls, for example, or sepsis, or diabetic ketoacidosis, or, you know, surgical complications, that sort of thing. Really important, make it short and succinct though. Don't say on day 4, had florid diarrhea, which was later diagnosed as C. difficile secondary to the amoxicillin. Just say C. diff secondary to IVs. Anyway, procedures performed, self-explanatory, and it should be pre-filled, my understanding is anyway. Medications at admission. Guys, in the hospital system I worked in, we had fantastic pharmacists who would often, but not always, put this in. When I say often, not always, it's not because they're lazy. It's because there was usually one pharmacist to like 200 patients. Really, really hard. And some of our patients are really complicated and are on like 60 medications. That's an exaggeration. You know what I mean. Please put in the medications the patient says they were on admission, because it sometimes doesn't line up with what we have on our system. Then, of course, there's the medications at discharge. And I will argue that this is the more important thing, but please, both are really, really important. Basically, you have the brand name, the direction, strength, status. So is it new and temporary? Was it discontinued? Was it new, permanent, that sort of thing? And reason. So tell me why they're on these things. It's really important because some medications have about 6 different indications. Then there's adverse reactions, so any new allergies or whatnot, please put in the old ones as well. Alerts, follow-up arrangements. If you have put in a blue slips referral, which I think might just be a local thing, but an internal referral to an outpatient department, please let me know. If you want me to do something, that comes later. But basically, did you arrange them to come back to a certain clinic or need blood tests? Let me know. Then there's the recommendations to GP. And maybe it's just me. And maybe it's only when I'm lazy. But I often scroll to this part. This is the time to summarize and succinctly put what you want us to do. I will give you a couple of key don'ts in a minute, but essentially, this one's actually really, really good. Dear doctor, I'm writing to update you about a year old blah 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 who was admitted with X with Y due to Z. Perfect. At this time, she is blah 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 symptoms, and the follow-up we have started, well, the treatment we have started is XYZ days of blah 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 medication. A follow-up with the specialist has been organized for this date. It is recommended that a repeat blood test, repeat ultrasound, repeat CT be done on this date for you to organize. If you have any questions, don't be afraid to hesitate to contact us. You don't have to be that polite. This is really, really, really nice. But be polite. You don't have to be that wordy, I should say. Now, if you are writing a discharge summary, please never ever write GP to Chase. We are not dogs, we are also specialists, just like your consultants are. If you want us to follow up anything, please CC us into the results. Also, please don't ever write do the necessary or do the needful. Obviously we're going to, it's null and void, save your keystrokes. Also, don't be afraid to make suggestions if your consultant has. So, consideration of up-titrating X medication on blah 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 days. We are specialists, but we are not subspecialists like your cardiologist might be or hematologist or blah blah blah. If they've made a recommendation, it's actually really, nice for us. We really value our colleagues' opinions and their insight. Then there is recommendations to patients. Please do fill this in because patients can get their discharge summaries and they actually should leave with one. Basically say, please finish your antibiotics on this date, please see your GP in 14 days, please attend this appointment, if you have XYZ symptoms, come back. Then there is the care plan summary, so the summary of the plan. Finish antibiotics, see da da da. Yes, you're probably repeating yourself, but it's really, really useful. Then there's a lot of pre-filled things, test results, and yeah, pretty much just test results and then who gets it. Please just put in the necessary stuff. As the GP, I don't actually care too much about their blood gases in ED, but I do really care about their cultures. But basically guys, take care when you're writing your discharge summaries. If you have any questions, ask a colleague, ask a friend, and pretend you're on the receiving end and see if what you wrote was actually helpful. I hope you did find this video helpful. Apologies for the rambles. But if you have any questions, let me know. Press like, subscribe, bell, comment, all that YouTubey stuff, and I will see you in the next video. Until then, stay safe and stay healthy, and good luck in 2021. Bye.